All right. Well, good afternoon, everyone, and welcome back. We are now transitioning to the afternoon session of our meeting, and we are moving away from human health a little bit and going into animal health. And we're delighted that we have our panel with us and with our moderator, Dr. Claire Burbick. Take it away.
Thank you, Dr. Musmart. Please join me in welcoming our next set of panelists. Our second panel this meeting will focus on companion animals and the unique position they reside in for both public and animal health when it comes to drug-resistant infections. Today, we will hear from Dr. Scott Weiss, a professor at the University of Guelph, Ontario Veterinary College, Dr. Stephen Cole, assistant professor and director of Clinical Infectious Disease Lab at the University of Pennsylvania, Dr. Karen Alroy, lead of the One Health team in the antimicrobial resistance unit of the New York City Department of Health and Mental Hygiene, and Ms. Melissa Cummings, a senior epidemiologist and program manager of the HAI-AR program at the Massachusetts Department of Public Health. I'm very excited for this panel. Thank you all for taking the time to come and share your knowledge with us. Please begin, Dr. Weiss.
Great, thank you very much. So let's just skip over the first slide here. So asking the question about what's the regulatory position of companion animals? Well, it's by default they're animals. So animals, we usually focus on food animals. Companion animals are essentially there by default. There's very little to anything that's going to say except companion animals. But to a large degree, they're invisible. So they are included. We do get consideration of them, but usually there's not a lot of thought that goes into the dynamics that are involved in food animals or in companion animals, which can lead to some missed opportunities and some unintended negative consequences. We get the next slide. If we think about why, historically, ag and public health is focused on food animals. That's how our systems have evolved. They focused on food animal and zoonotic diseases. Most of the expertise, most of the attention that's out there is really focusing on food animals for good reasons. The data we have focus on food animals. The main human health risks probably relate to food animal antimicrobial use, but we really don't understand the scope of the problem. And that's a big issue overall with antimicrobial use in animals. But in particular, in companion animals, we know there are zoonotic disease risks. We really can't classify those in terms of their overall importance. And part of the reason is we don't have any surveillance, or at least organized surveillance systems that structurally, in an integrated manner, consider companion animals amongst broader antimicrobial resistance and use surveillance. So overall, that means we end up with less understanding of the problem. We have less motivation because we don't understand it. We don't have as many people with stakes in it. We have less engagement, and we don't have proactive thinking. We're left with a purely reactionary approach should we run into a problem. Next slide. And a lot of this comes down to some simple aspects, right? If we're talking today, if someone says to you, what do you think about when antimicrobial use in animals is mentioned? And on to the next slide, most people would probably think this: large groups of animals, large amounts of antimicrobials, food animals. Now, if I switch it around for the next question, what's the focus when we think about antibiotic stewardship in animals? Next slide being probably the same thing, right? We focus on large groups, a lot of attention on prophylaxis, but food animals, group treatment, not specific individual animal treatment, which is the predominant route of use of antimicrobials in companion animals. And with the next slide, we just have to remember that our scope of animals is very broad. And we have these large groups of food animals, but we also have the companion animal that's living in your house, living on your bed, licking your face. We have these hybrid food and companion animals, such as backyard chickens, which are a really difficult issue. In many parts of the world, we still have working animals that fit outside of all these different areas. And we need to think about the relevance of these and the different types of contacts and risks that we have. An example I use for pets is, well, if you own pets, think about it. Think about the contacts that you have with individuals, human or animal. Duration, closeness, intensity, whatever you like. And for most people, it's going to be, a spouse or your partner, and then maybe your small kids if you have small kids, and probably your dog or your cat if you have one of those. And if you don't have kids or you don't like your spouse, then they're higher on your list because we spend a lot of time with them. We have close contact with them. We have that degree of interaction that we don't have with a lot of other individuals. So it creates opportunities for pathogen transfer in both directions, and it definitely does go in both directions. So if the next slide, and I'll apologize to who's advancing the slides, this is going to be a bit of a rapid fire, but just an example, bring it down to the micro level. So I'm still a clinician, I still work with patients, and this kind of ties in that patient to the population dynamic for me. So this is Meg. Meg's a middle-aged Labrador Retriever, a bit on the fat side, like a lot of middle-aged Labrador Retrievers, and she blew her cruciate ligament, like a lot of middle-aged Labrador Retrievers. Next slide, she had a procedure called a tibial plateau leveling osteotomy. It's the radiograph on the left, pretty major surgical procedure. High-risk procedure for infection compared to a lot, and she did get an infection with a multi-drug resistant staphylococcus. So this is the dog version of MRSA. This is methicillin-resistant Staph pseudoneuritis, and it's resistant to, well, everything on this panel. We had a couple options, but not a lot of options. So as a clinician, that's my oh crap moment. I've got to deal with a patient that has a deep infection that I want to try to treat. But we need to think about the broader aspects that the next slide brings up, because it's not just, actually we'll go one more slide. It's not just the interaction of the dog and the bug and the antibiotic. We've got this broader thing we need to think about, which we don't necessarily think about as much with other species. So we got in the middle there, Meg's got high-risk contacts. She lives with an infant, someone that's higher risk for picking up a zoonotic pathogen. This isn't Meg to the right there, but this is what Meg did. Hospital visitation programs, goes into human healthcare facilities, interacts with high-risk individuals. And actually the bigger risk for these dogs is what they pick up from people in hospitals, but things can go both directions. From my standpoint, if someone runs our hospital infection control program, I don't want her spreading things around here, exposing staff, exposing other animals. And then we've got this social dynamic and the mixing dynamic that, again, we don't have with a lot of other species. Meg's a normal dog. She goes to the dog park, hangs out with other dogs, other people. What goes in comes out. That applies to both antibiotics and resistant bacteria. So we have other direct contact exposure as we have environmental and contamination aspects. We bring in a lot of interesting dynamics here. Next slide. When we look at, actually one more slide. When we look at numbers, these are Canadian numbers. They're probably pretty similar to the US. In gross tonnage, kilograms, whatever you want to use. Antibiotic use in companion animals is dwarfed by food animals, not surprisingly. We have a lot of food animals. They're large animals, many of them. We use a lot of antibiotic there. But we have to think about this 1%, because 1% of a very big issue is still something that's relevant. The other thing is tonnage, kilograms. These are really crappy indicators of how we use antibiotics. They're very, very crude. They don't tell us a lot about why. They don't tell us about the relative importance of drugs, especially the higher tier, newer drugs, which tend to be dosed at much lower milligram per kilogram bases. So we can use a lot more higher tier drug and kind of sneak under the radar. So companion animals, we don't use anywhere near as much antimicrobial in them as we do in food animals, but we use a lot, and we use important drugs. And the next slide will just be a little bit of a snapshot into that. There's some data we just published a few weeks ago now. And actually, this is an earlier one, but these are looking at a few different veterinary clinic networks, so small animal clinic networks in the US, Canada, and the UK, and predominantly in the US. And this is just a snapshot, a subset of clinics that are in the US. But if you look at 2.5 years of data, over 20 tons of antimicrobials. Yes, I said tons is a really crappy indicator, and it is. But just trying to put it in scope that, 1% still is a lot when there's a lot of antimicrobial that gets used. If we look at this graph on the right here, we can see the blue is the critically important antimicrobials as classified by the WHO, and the green is the highest priority critically important antimicrobials. And there's a lot of them. And it's these highest priority ones tend to be dosed at fairly low milligram per kilogram levels. So you underestimate the amount of use with this. So take home is we have a lot of antibiotic use in companion animals. We tend to have a lot of higher tier drug use. And the next slide, we have a lot of resistance issues. And I know we're going to get to some of this, including the bottom left one there later on today. But we see many antimicrobial resistance issues. We see transfer of organisms between humans and animals in both directions. And we don't really understand the scope of the problem. We don't understand the risk to humans, animals, or the environment, this whole One Health triad. But a lot of the concepts that we think about for food animals really should apply for companion animals. So if we look at the next slide, this is the global leaders group's priorities or main talking points about animal health and welfare with antimicrobial use. And this shows that a lot of things that we do from a regulatory, from an advocacy standpoint in food animals really do apply to companion animals, but sometimes there are some missed opportunities or some problems. But the main focus is so robust animal health systems. Again, more we can do to prevent disease, the more we do to reduce antibiotic use. Remembering that animal welfare is a key component. We use antimicrobials for a reason. The floor is not zero. The floor is used as little as possible, but as much as needed, right? And we have to figure out what that is because they're essential medicines. So responsible use is really critical. We don't have the non-veterinary, the growth promotion use in companion animals. But the bottom point, number 6, the need for integrated surveillance that's standardized, comparable, communicated, really does include companion animals as well. So there are a lot of similarities. If we go to the next slide, we have to think about the differences too, because these can cause the problems. It's the little things that can cause the most damage sometimes. So what are the differences between companion animals and food animals? Well, a lot of those are, I think, quite obvious, but we have abundant extra label drug use in companion animals. Sometimes that's because we just don't have as many drugs for certain species. We don't have label indications for the breadth of diseases that we treat. In companion animals, we tend to treat a lot more variety of infectious diseases than you do in food animals, where there tends to be a fairly narrow repertoire, or at least of really key infectious diseases. We have extra label drug use, extra label doses quite abundantly, a very wide range of drug classes, including most of the drug classes that are used in people, apart from some of the really new drugs that are used in humans. But even those, we get some trickling into animal use. And I'll come back to that in a minute. We use drug classes in companion animals that we don't use in food animals, or would exceptionally rarely use in food animals. Higher tier drugs like carbapenems, glycopeptides, oxylinones, drugs like nitrofurantoin, or drugs that we just are banned in food animals, such as chloramphenicol, and a lot of use of higher tier drugs for various reasons. The next slide. So we also have a lot of different pressures that come into play. When you think about stewardship and you think about restrictions, you think about ways to modify behaviors, we have to remember this psychological and the pressure component. It's not very common for someone to go to the vet and say, do everything you can do to save this chicken, right? Don't imagine that's been uttered very often. That gets said a lot to veterinarians about dogs and cats. Do everything you can do. Money is not a concern. If money is not a concern, higher tier drugs aren't necessarily a concern. Horses, which kind of bridge this companion animal, food animals, we see this quite a bit with expensive racehorses. When the value of the animal and the pressure to get this animal back in production, racing is very high, the cost of a higher tier drug is very, very low in relative terms. And we see a lot of overuse, misuse of high tier drugs because of that. Companion animals typically have a long lifespan, longer cumulative exposure risks. You know, it varies. Dairy cow can live a long time, a chicken not very long. Dogs and cats tend to be there for quite a while. So we have chances for repeated exposures, which create different types of risk than the big bang exposures of a food animal that get antibiotics now, and their lifespan is fairly short. We don't have withdrawal considerations, the milk and the meat withdrawals. So we have different drivers. The human-animal contact types are very different. So your food animal doesn't have a lot of contact with the general public, certainly, but a lot of people in general. Your companion animals do, in the duration, frequency, closeness of contact. And we have much different drivers of why we use antimicrobials. And that's impacting, how we control things, because what drives antibiotic use is what we need to think about with stewardship approaches. And that brings in some barriers sometimes with companion animals. And the next slide. So back to the regulatory space. Like the regulatory space, I think, is fairly straightforward. They're animals. They're lumped in as animals, even though they're not considered as part of animals. And this becomes a bit of a problem because we miss opportunities and we create potential issues because things that get done for animals are almost always focused on food animals, where they might make absolute sense, but where there might be issues when we bring in companion animals. There might be assumptions that apply that don't apply to companion animals. There might be unintended consequences. And we're seeing this quite a bit in Europe with restrictions that have been placed there, which is creating substantial problems for things just like even routine perioperative antibiotic use, when the best drugs, the main drugs, the recommended drugs, and what we want to put into the guidelines are extra label, which brings in a restriction. And we see some situations where by the letter of the law, you would need to use a higher tier drug or a suboptimal drug because the best option isn't on label. Right. So we need to think about how we tie all these things and what's our net goal and how do all these measures kind of impact that for good or for bad. Next slide. So I think I went over some of this already, but unintended consequences, restriction of certain drug classes leading to an inability to treat in certain animals, right? Some of these higher tier drugs, we don't want to use them very much. We don't want to contribute to resistance. Stephen's going to talk about carbapenem. It's really, really important drug class. But we need to think about what's the role of them in very rare individual animal medicine. Should we be saying, no, euthanize them, you can get another animal, or saying, yes, we can use them under certain circumstances if we do it right? And you'll get a lot of different arguments towards that. Restriction of extra-labeled drug use, like I mentioned, which can limit effective treatment options, can drive suboptimal approaches, and can potentially drive the use of higher-tier drugs. And a lot of confusion when it comes to prophylaxis, because when we talk about prophylaxis, we can head to the next slide. When you mention prophylaxis, it's like those earlier slides. People think about 1,000 chickens, 1,000 pigs, widespread antibiotic use that probably can be massively curtailed. And that's true because prophylaxis is a really, really wide area. And most of the prophylactic approaches really apply to food animals. So a large group administration. But at the bottom of this list is administration of antimicrobials to a specific animal at a specific well-defined high-risk time, such as surgical prophylaxis. And that's something that's highly beneficial, highly useful. It's part of good antimicrobial stewardship. But if we focus on prophylaxis bad and lump everything into prophylaxis, we can create more problems, create more disease, potentially create more need for therapeutic antimicrobial use. So just ending off for the last slide here. So we've got a lot of issues that we have to think about, and I'm not trying to downplay, saying companion animals should get a free pass, because there are major issues. We've got definitely excessive antibiotic use in companion animals. It's clearly a problem. Higher tier antibiotic use is particularly a problem. Use of these new broad spectrum or kind of niche drugs in human medicine raises concerns too, because it's a slippery slope. Start using them once, you start using them more. Stewardship principles really aren't that well ingrained in companion animal medicine. The individual animal medicine aspect and the owner pressure are often more apparent to that. I've got a patient in front of me, I've got an owner in front of me, I want to make them happy and healthy. Yeah, resistance is important, but that's someone else's problem, or that's a down the road problem. And multi-drug resistant infections are increasingly common in companion animals, and some are zoonotic. So we obviously have some concerns that we can't ignore this issue. So my last slide there is just some contact information if anyone has any interest, but with that, I think we'll pass it on. I'm happy to take questions later.
Thank you, Dr. Weiss. Dr. Cole, are you ready?
Yes, absolutely.
Okay, go for it.
All right. Well, thank you everybody so much for having me today. It's very much an honor to speak to all of you. There's a lot of people I really admire on this panel, so I'm just so glad to be here, and I'm so glad to see so many veterinarians represented on it too. It warms my heart for sure. So as many of us know, carbapenemase producing organisms are an urgent health threat globally. Next slide, please. But what some may not know is that relatively recently there has been an increase in the number of reports of companion animals infected or colonized with carbapenemase producing organisms, including a number of high-profile outbreaks. In a few of these cases, people and animals have simultaneously harbored the same strain of CPO. However, it's been difficult to establish the directionality of the relationship of that bacterium. Today, I'd like to review recent work in CPOs in companion animals and how actions by the federal government could help further our understanding of the problem and promote rapid responses to these issues. Next slide, please. In 2018, our group described the first report of ongoing transmission of a carbapenemase-producing Entobacterale, in this case an NDM-producing E. coli, across animals at a veterinary facility in the United States. Well, this cluster of cases initiated with just 2 organisms. The organism lingered within the hospital and somewhat silently spread until ultimately 15 cases of animals were identified over the course of a year. It's important to point out that this was at a veterinary hospital where there were already robust infection prevention processes in place. There were responses made to specific phenotypic results that were seen. and it was a well-resourced veterinary facility. But even in the well-resourced veterinary facility, we saw significant challenges and ongoing challenges in controlling this outbreak. Given the novelty of this issue, there were many lessons learned in our response and has spurred many questions for us. In this case, the ongoing transmission was ultimately linked to the reuse of endotracheal tubes, which is a commonplace in veterinary medicine. And it's meant to reduce the cost of surgical intervention for owners. However, it has an accidental risk of potentially transmitting important organisms. It is just one example of how balancing the costs of veterinary care in the face of an affordability crisis can often be in tension with spreading of emerging pathogens. One critical way to combat, next slide, please. One critical way to combat carbapenemase-producing organisms within companion animals is to ensure robust surveillance programs are in place and are well supported. So in fact, the previous example was first detected because of our participation in the FDA's Veterinary Laboratory Investigation and Response Network, or VetLearn, which partners with dozens of veterinary labs across the United States and Canada to track, test, and sequence bacterial isolates for mechanisms and patterns of concern. VetLearn is an excellent example of how current veterinary infrastructure can be bolstered by the federal government to advance knowledge and capacity for response to AMR threats in companion animals. I personally believe that additional resources and funding to VetLearn for AMR efforts is low-hanging fruit for high impact that could be advocated for by PACCARB. Next slide, please. And the work of VetLearn has also continued by supporting the very first surveillance project in companion animals for CPOs in the United States, which was led by my laboratory. This study included 8 veterinary teaching institutions from across the United States, including PACCARB's own Dr. Berbick's lab at Washington State University. The good news is that we found, after screening over 2,300 fecal specimens from dogs and cats, the prevalence was relatively low at 0.21% of animals. However, it is important to recognize that there are over 80 million pets in the United States, and that this, if reflective of the overall population, could represent a large number of individual animals that are colonized with CPE. This is obviously also has the ability to grow and expand over time, especially as veterinary medicine continues to become more advanced and antimicrobial resistance continues to spread, particularly without intervention. Next slide, please. Another important partnership that we've had in my lab is with the Philadelphia Department of Public Health. This led to the development of a robust biosecurity program, including improvements to our infection and prevention and control at our facility, as well as the development of an actionable screening approach. Regionally in Philly, we've found over 150 animals that have been colonized with CPOs. These data are presented here in several ways to help describe this emerging problem in companion animals. In the top left, cases that were suspected to be hospital-acquired are in light green, whereas cases of animals that were admitted to the hospital already positive for CPOs are in light pink. This shows that both veterinary hospitals and community spread may be playing a role in the spread of CPOs in companion animals and are important for further investigation. On the top right, this demonstrates the silent threat of CPOs in animals. The orange represents CPE colonized animals found by rectal screening, and those in purple, the few of them, are animals with infections diagnosed by routine culture and susceptibility testing. Without active surveillance, the scope of the problem is limited to only those recognized by culture, which is costly to owners and therefore doesn't represent the full population of animals. In the bottom left, it shows the genetic diversity of the CPOs that we've isolated in our biosecurity program. And it highlights that there's a mosaic of different types of CPOs that can be found among animals and likely represent varying levels of threat and concern. Finally, in the bottom right, through repeated testing, we've demonstrated that the risk of CPO carriage can be prolonged in many animals, with most animals that are colonized being colonized for more than 90 days. The federal government has the capability of enhancing the capacity of local and state health departments to partner with veterinary facilities to respond to CPO cases to prevent spread between animals and potentially to people as well. We'll do the next slide. We also have recently completed a pilot study that sampled the environment of 15 different veterinary hospitals in the Philadelphia region. And we found CPOs in 6 of those hospitals. Most commonly, they were found in large referral hospitals with more sick, more advanced care, and more vulnerable populations of animals. Interestingly, we actually found evidence of the exact same strain of CPO and Enterobacter hermatiae, which harbored an NDM7 carbapenemase in 5 of those 6 hospitals. CPOs can potentially become endemic within veterinary facilities, but also move between veterinary facilities as well. This same strain has also been isolated from animals in Connecticut, Washington, D.C., and Texas. It's possible what we're seeing are very successful strains of CPOs emerge in pets and disseminate across the country. Next slide, please. Another example of some excellent work that's been done, and actually the author of this is in the room, Dr. Callie Habron, today, which was a surprise to see her, and I was excited to see her. But it was an interesting case that was presented on CDC's Zohu call, where an NDM-producing E. coli was found in 37% of animals at an animal rescue facility. Interestingly, the index animal was originally imported into the United States from abroad, which is actually reminiscent of what we see with NDM infections in people, with one of the biggest risk factors for NDM infections being hospitalized abroad. People may not know, but there are over 1 million dogs and cats imported into the United States annually. And there's a potential role for the federal government to play in monitoring for these antimicrobial resistant threats if they're brought into the country that way. Next slide. So modern techniques such as whole genome sequencing have really helped us further our understanding of the relatedness of animal and human CPOs. When we compare animal isolates to those sequenced by public health laboratories and the CDC's antimicrobial resistance laboratory network, we find that many of the bacterial isolates are closely related to human infection isolates, which suggests that there's a potential role for animals to both serve as a reservoir of CPOs, but also for bidirectional spread between pets and people. And we'll go into some examples of how whole genome sequencing on the next slide, please, has helped us investigate some of that. These are some important examples of investigations that have been initiated because of whole genome sequencing surveillance that has included carbapenemase-producing organisms from companion animals. The first is animals connected to an outbreak of carbapenemase-producing Pseudomonas aeruginosa. That was a large-scale outbreak that's well known in artificial tear and eye drop products that occurred over the past couple of years. And we actually, at my laboratory, isolated the exact same strain causing infections in 2 dogs with bacterial infections and worked alongside the New Jersey Department of Health to actually investigate these animal cases. Well, we unfortunately never found the source of it in the animals. This allowed the New Jersey Department of Health to issue advisory guidance to veterinarians to warn them about the lookout for infections caused potentially by these contaminated products when they're causing disease in people at the same time. The second example is a community outbreak of NDM Klebsiella pneumoniae that is connected between animals and people in Massachusetts. And this work has been supported by a unique grant collaboration that we have with the CDC Pathogenomics Centers of Excellence. My lab is an academic partner to the Minnesota Department of Health's PGCOE Center. And this unique funding mechanism has joined academia and public health laboratories to develop a framework for One Health investigations of CPO outbreaks. But resources still very much remain limited. And Melissa Cummings will actually present this more in depth as the last part of this session. So I'll move on to the next slide. There are several areas in which I believe PACCARB can advocate for specific actions that can be taken to advance our understanding in response to CPOs and companion animals. First, I believe we need to increase funding for companion animal antimicrobial resistance research and to expand our current surveillance capacity by supporting networks like VetLearn, the National Animal Health Laboratory networks to do this sort of work. and to access federal programs that might not traditionally be accessible to veterinary experts, for example, like the Pathogenomic Centers of Excellence. One theme that I've heard today is about the rapid growth of healthcare. And I want to say that the exact same thing has been happening in veterinary medicine for sure. We give more and more advanced care to our animals, and therefore that's leading to more and more advanced infection issues. And unfortunately, veterinary medicine has really outpaced the fields of veterinary infection prevention and veterinary antimicrobial stewardship. So I believe we need to develop incentives not only to academic and public health partners, but also within the private sector to implement these important tools that encourage growth of these fields for certain individuals to enter into, considering things like debt loan forgiveness. And lastly, funding is needed to support outbreak responses and investigations within veterinary settings to prevent the spread to people before the spread happens, and to promote veterinary and Department of Public Health relationships and collaborations to occur to prevent the spread of these organisms. Next slide. I also have to say that another theme I've heard today has been workforce development. And one thing that I really want to advocate for while I'm here is for federal support for the development of veterinary clinical microbiology as a specialty. Both Dr. Burbick and I are veterinary clinical microbiologists, and we direct accurate, fast, and responsive veterinary microbiology labs. We identify resistance patterns at the laboratory level and liaise with public health. We provide capacity for surveillance and outbreak response, and we often advise since there aren't ID docs really that well established in veterinary medicine, we often serve as the front line as ones who consult on therapeutic options and promoting antimicrobial stewardship in the microbiology lab. And unfortunately, the American College of Veterinary Microbiologists only has 7 active residencies. We only take one at a time, and we're not growing our workforce at that point. And I can say as a director of one of those programs, it's a very hard thing to fund, incredibly hard thing to fund. And so I believe that specific access to funds to build the front line of antimicrobial susceptibility testing and resistance monitoring in animals is critical to any One Health activity that PACCARB is going to recommend. This is both critical to the agricultural industry, but also a key public health need. Next and last slide, please. I just want to take the last little bit of time to say why this really matters. So first, pet care and veterinary medicine is a large and growing industry in the United States that we should absolutely protect. But even more so, I want us to protect the human-animal bond. Our pets help us live happier and healthier lives. We know that they help us improve physical activity. They help us to maintain social connections and routines, and they provide important companionship to many, many people. Americans, just like shown here in my own home, live closely and intimately with their pets. I have to say, I agree with Dr. Weiss. I definitely kiss my dogs more than I kiss my spouse. And for example, we have Princess Margaret, the Cavalier King Charles Spaniel, who sits on my shoulder every night. And then we have Adler, our Philadelphia Terrier, that's the former name, sleeping in our bed. We sadly, unfortunately, lost and said goodbye to Adler 2 weeks ago to a long battle of lymphoma. But I can very much tell you firsthand how much our pet people that they are so, so important for. So it's critical that we prevent antimicrobial infections in our pets, but also that will help us to prevent the spread potentially to the people who care for them and who love them. Thank you very much for your time today.
Thank you, Dr. Cole. Dr. Alroy, you're up.
Thank you so much. Good afternoon, everyone, and thank you so much for having me. It's just such a pleasure and honor to be a part of this panel. So my name is Karen Alroy, and I'm a veterinarian and medical epidemiologist at the New York City Department of Health and Mental Hygiene. Next slide. So as you've heard now, many carbapenem-resistant organisms, or CRO, are considered urgent threats to public health, and companion animals can become infected or colonized with them. Next slide. Carbapenemase-producing organisms, or CPO, are a subset of CRO that can produce enzymes that break down carbapenem antibiotics. And these are public health priority because they can easily pass their resistance genes from bacteria to bacteria. Next slide. And different lab tests are used to identify CRO versus CPO. So antimicrobial susceptibility testing can determine if a bacteria is resistant to a carbapenem antibiotic. And vets use this to identify the cultured bacteria and to know which antibiotics will likely work to treat the bacteria. Molecular testing can determine if a CRO has the genes or genetic code capable of producing a carbapenemase. And phenotypic testing can determine if the bacteria is actually producing the carbapenemase enzyme. Next slide. So while there is strong evidence that people and pets share their microbes, we have limited data to know if and how CRO in pets impacts public health. Next slide. So before I delve in, I want to share my take-home message up front. These are 4 ways that we could improve the detection of CROs and reduce the spread of resistant bacteria among companion animals. The first is to support antibiotic susceptibility testing in pets, identifying ways to make the cost of susceptibility testing not only fall on the shoulders of pet owners. Making phenotypic and molecular testing of resistant bacteria from pets more accessible is really important, since right now, very few labs offer these tests outside of research and public health settings. Improving informatics and automated reporting from veterinary diagnostic labs to public health departments could be incredibly useful to help improve case finding in a timely way that can enable public health action. And then ideally, if we can strengthen veterinary infection prevention using the basic principles that we know already work to reduce disease transmission generally, then we can potentially also reduce transmission of resistant bacteria. Next slide. So one of the primary reasons we don't have a firm grasp on the public health risk of CROs in pets is because there's limited public health infrastructure to detect these resistant bugs in pets. So in general, when I think about population level surveillance, I think of it like a pyramid similar to this one. And we acknowledge that there are numerous barriers that must be overcome before data makes their way to our desks in public health. So I'll walk us through this schematic and start at the bottom. We know pets can be colonized with a CRO and have no symptoms. Pets infected with a CRO will experience symptoms, and this will alert the owner that there is an issue and something might be wrong. If the owner brings the pet to the veterinarian, some vets might recommend conducting a culture and sensitivity test. But, it's important to recognize that that's not a routine practice. One study found that only 4% of the time when veterinarians are prescribing antibiotics are they also offering antibiotic culture and antibiotic susceptibility test. And these cultures are more frequently recommended for pets with chronic or recurrent issues. And it's really the cost to the owner that's the greatest barrier as to why vets are not recommending these tests more often. So in the circumstance that the vet offers the culture and sensitivity, the owner must agree to pay for it. And then it's sent off to the lab, but the diagnostic lab might not test routinely for carbapenem sensitivity to carbapenem antibiotics. But if they do, they can identify a CRO in a pet. Public health then needs to be notified about this test result. There was a really nice survey that CDC did of several veterinary diagnostic labs, and they found that 2/3 of the surveyed labs would not report a carbapenem-resistant organism to public health if one was detected. So if you can get through all these different barriers, public health can potentially learn about a CRO in a pet and begin an investigation. So next slide, please. So in New York City, we are using multiple tools in our toolbox to try to monitor CROs and pets, and ultimately to try to examine the risk that they pose to public health. So the first approach is to try to establish a legal framework for reporting. And in my bureau, the Bureau of Communicable Diseases, the principal way we monitor for human and animal diseases is to require reporting from the New York City Health Code. And medical providers and labs report diseases at the time of diagnosis. So the second approach that we're taking is to engage in voluntary collaborations with veterinary diagnostic labs. And there are 2 categories within this, retrospective as well as prospective. So for the retrospective data, we request that veterinary diagnostic labs share with us CRO data from New York City pets from a certain time period in the past. And for the second avenue for prospective data, since phenotypic and molecular testing really doesn't have a commercial market value, most of the vet diagnostic labs don't offer these tests or have the capacity to run them. So our request is that after veterinary labs complete their culture and sensitivity testing, that they send their leftover CRO isolates to Dr. Cole's lab or another lab that's capable of doing the phenotypic and molecular testing. And so we've been in communication with a couple of veterinary labs about a possibility of a project like this, but at this point, nothing prospective has yet been established. Next slide. So we have received some retrospective data from IDEXX Laboratories, one of the large commercial veterinary diagnostic labs. And these data confirmed that dogs and cats in New York City veterinary clinics have had CROs, and it gives us really a rough estimate of the scope of the problem. So from 2019 to 2022, the lab identified 256 gram-negative CROs from approximately 16,000 gram-negative isolates, representing about 1.6% of all the gram-negative isolates from this one lab. And while this has been very useful to understand the larger context of CRO and pets, really that top part of the pyramid that I was illustrating before, these data have important limitations. One is that often there was a substantial time difference between when the specimens were collected and when we received the data. So sometimes it's up to several years. And the second is because we do not have the names and contact information of the vets who submitted these specimens. So for these two reasons, we really haven't been able to use these data to further do public health investigations to better understand what might have transpired and how these animals got these bugs. Next slide. So we returned to that first tool in our toolbox, and we wanted to lay the groundwork for the legal mechanism to request reports of animal CROs. So late last year, we made an appeal to our Board of Health. There was a public comment period, and early this year, the New York City Health Code was amended to make CROs and animals reportable. We distributed a health alert to the New York City vet community, and this alert was also added to the newsletter for the Veterinary Medical Association in New York City. So this is really the start of what we anticipate to be a long process of raising awareness about CROs and the need to report CROs to public health. Next slide. And the reason why we anticipate this being a long road is because we know that manual disease reporting from veterinarians for surveillance purposes, we can't rely on that alone. Public health really benefits from automated disease reporting. And while there's great value in medical providers or veterinarians calling the health department to report a disease, really the vast majority of our routine disease surveillance for both human and animal diseases comes from automated reporting. And I'll give you two examples here. So the figure on the left shows all the diseases that were reported to our bureau in 2022. It's roughly about 70 diseases, and this shows all of them except excludes COVID-19 and also the exclusively lab reportable diseases. So even when providers can report by phone or by paper, really most reports are coming in electronically, so 96% in this case. And the human diagnostic labs mostly submit reportable disease results electronically using Health Level 7 or HL7, which is a standard framework for exchanging electronic health information. And most of the automated disease reporting infrastructure in the human labs was built from the meaningful use part of the 2009 federal stimulus, which tied Medicare reimbursement and incentives to the meaningful use of healthcare technologies, including electronic exchange of health information. So there has not been an analogous investment in companion animal informatics in the same way. So the figure on the right illustrates the New York City canine leptospirosis surveillance. This disease has been reportable since 2007. And you can see that reports that came from labs are in blue, reports from veterinarians are in green, and reports that came from both sources are in the cross hatch. And you can see that most of this reporting is coming from labs and not directly from veterinarians. Plus, there's an interesting detail about this graph. So most of these lab reports come from the two largest veterinary diagnostic labs that service our nation. And one of these labs had an automated fax-based system in place and has been reporting through that automated fax-based system since 2007. And the other created an automated email-based system just last year in 2023. But before that new email-based system was in place, we did not receive any canine leptospirosis reports from that second laboratory. So while any automated system is better than no automated system, we really can do better than fax and email-based reports. Many vet diagnostic labs have informatics capabilities, but there has been no push to standardize veterinary informatics messaging to public health because there are no repercussions for not doing it, and there's no demand to do it, such as a commercial demand or an incentive structure. So animal CRO reporting has not yet been incorporated into the automatic reporting from these veterinary labs. So it should come as no surprise that since the Health Code Amendment earlier this year, we have not received any reports of CROs in animals. But we're planning a series of outreach meetings this year to help raise awareness. And most importantly, we're really optimistic to continue collaborations with our commercial veterinary lab colleagues to request that they include microbiology data in their automated systems for public health reporting. Next slide, please. So an important reality in public health is that we don't always have the ideal data to guide our actions. And sometimes you still need to act to help to stop the spread of a pathogen, even in the absence of ideal data. So this slide highlights findings from a recent survey of 466 veterinarians from across the nation, looking at their knowledge, attitudes, and practices on zoonotic diseases. And the survey confirmed that zoonotic disease transmission is occurring among veterinary personnel. 19% of respondents acquired a zoonotic disease from their practice just this past year prior to taking their survey. The survey also found that 40%, or so less than half of respondents, had a written infection prevention plan or guideline at their practice. But yet 90% of the veterinarians reported that they believe that vets are vital in promoting zoonotic disease prevention. And survey respondents also shared that they wanted more support in doing that. You know, they wanted easily accessible zoonotic disease information online. They wanted materials for a veterinary audience and materials for pet owners. So even while we continue to build CRO surveillance and data systems, these findings can help guide our public health actions in the meantime. You know, there are tried and true prevention activities that can generally reduce disease transmission overall that could also likely reduce the spread of resistant bacteria from companion animals. Next slide. So just to reiterate my take-home message from before, the 4 recommendations that could potentially improve CRO surveillance and reduce the spread of resistant bacteria among pets. You know, creating a funding mechanism to pay for antimicrobial susceptibility is important. We really can't rely on owners for this cost, especially if there's a need for public health to better understand these resistant bacteria in companion animals. We also need public health support for phenotypic and molecular lab testing of isolates from pets. This is really such a niche kind of test with almost no clinical value. So public health needs to take the lead to try to enable this type of testing in order to make it more accessible. And this could be done, for example, by strengthening some of the testing via existing laboratory networks, such as the CDC's Antimicrobial Resistance Lab Network or the FDA VetLearn program. The third is the need to improve informatics and automated reporting from veterinary labs to public health. I suspect that incentives for these laboratories to enhance interoperability for more real-time reporting could really go a long way. I have found really great partnerships and colleagues at these labs. So I think there's willingness and interest to do this sort of thing. And lastly, we can't wait until all of our data systems are all perfectly in place to start to take action. And improved veterinary infection prevention could reduce disease transmission in general and reduce the spread of resistant bacteria. And unlike in human medicine, the world of veterinary infection prevention is much more early in its progression, and helping to support the development of veterinary infection prevention guidelines and enhance training and dissemination could be incredibly valuable. So next slide. Just want to thank you all again for giving me the opportunity to speak with you today, and I look forward to the next speaker and the discussion afterwards. Thank you so much.
Thank you so much. Ms. Cummings, are you ready?
Yes, thank you. So good afternoon, everyone, and thank you so much for the opportunity to speak today about our state health department's recent experience with a One Health outbreak. Next slide, please. So first, I would like to just provide a bit of context on the Healthcare-Associated Infections and Antimicrobial Resistance, or HAI-AR program at the Massachusetts Department of Public Health. Broadly, our program is tasked with surveillance, prevention, and control of multi-drug resistant organisms, or MDROs, and other HAIs across the healthcare continuum. And while all HAIs are not caused by MDROs, many, of course, certainly are. In terms of the priority MDROs that we monitor and respond to, this generally includes carbapenemase producing organisms, or CPOs, as you've been hearing a lot about, also Candida auris, and any pan-resistant organisms. The primary activities that support this work within our department include on-site infection control response, or ICAR visits in healthcare facilities, and these can be done in response to a cluster or outbreak, or also proactively in high-risk settings, such as ventilator-capable post-acute settings. And as an extension of our ICAR work, we also provide extensive subject matter expertise on infection prevention and control across healthcare settings. Additionally, our state public health laboratory conducts whole genome sequencing, or WGS, of all CPOs identified, as well as those organisms that are pan-resistant, in order to identify novel gene targets and relatedness among isolates. All of this data generated by our laboratory is uploaded to NCBI in real time. We also do coordinate colonization screening of individuals potentially exposed to CPOs and CORS in healthcare settings with the support of the AR Lab Network and our partner laboratory, which is Wadsworth in New York. And we also oversee a number of initiatives to promote antimicrobial stewardship across the healthcare continuum. And lastly, but perhaps most importantly, and cutting across all of these activities, is a tremendous amount of data analytics conducted using a wide range of data sources. And the results of these analyses obviously direct our HAI-AR work. Next slide, please. So let's get to our recent outbreak experience. Last July, a veterinary referral hospital reached out to the department seeking assistance related to an ongoing CPO outbreak. It was very fortunate that a longstanding and collaborative relationship already existed between our state epidemiologist and public health veterinarian, Dr. Katie Brown, who many of you probably know, and this particular veterinary referral hospital. And this definitely contributed to their comfort in reaching out to us for support. So that was serendipity, I think, in action. The facility had been identifying clinical infections for some time in their ICU, but a recent cluster of 7 NDM producing E. coli infections prompted their call to us. The facility had already implemented some clinical and environmental screening with the help of Dr. Cole's lab at Penn Vets. And although this was a veterinary healthcare setting, Dr. Brown reached out to myself and my colleagues in the HAI-AR program, and the idea to conduct a veterinary ICAR was proposed by our team. As mentioned previously, our HAI-AR program has extensive experience dealing with MDRO outbreaks in human healthcare settings and has conducted hundreds of ICARs. So this seemed like a natural next step to support this veterinary referral hospital. ICARs are on-site infection control assessments. They are collaborative in nature. They utilize standardized tools to help the facility focus on areas and opportunities for improvement. So Dr. Brown, as well as myself and another senior AR epidemiologist, along with our assistant state veterinarian from the Department of Agricultural Resources, participated in this ICAR visit at the veterinary referral hospital last August. Following the visit, a comprehensive report with prioritized recommendations was shared and discussed with the facility and gave them something tangible to provide to their institutional leadership when lobbying for additional funding and resources to address the identified infection prevention and control opportunities for improvement. Next slide. So the report shared with the facility was very extensive. These are just a few highlights of our findings. We certainly identified many missed opportunities to perform hand hygiene or simply to perform it correctly. Gloves were not always being changed between caring for different patients. Patient care staff were the ones responsible for cleaning and disinfection in the facility, but they didn't really have the expertise for that or a clear understanding of required product contact times. We noted that sink hygiene was not being maintained. There was a lack of clear splash zones around sinks, and clean medical supplies were clearly within those splash zones and at risk of being contaminated by drain biofilm in these sinks where faucets were not offset from the drains. We noted confusion among staff with regard to precaution signage that was being used on cages in the ICU. Veterinary tape rolls were being shared between patients, which is not uncommon in veterinary healthcare, but it allowed for the sharing of pathogens as well. We also noted, as Dr. Cole mentioned earlier, some respiratory equipment was being reused when it was labeled as single-use or disposable. There was no policy regarding cleaning and disinfection of stethoscopes between patients, and we found that as a gap, as something that wasn't taking place. And lastly, we found instances of clean patient care supplies being stored on open shelving in patient care areas where they were susceptible to contamination. Next slide. Now, moving on, at the same time that we were supporting the veterinary referral hospital with their CPO outbreak, we were also conducting our typical surveillance and response activities to MDROs and humans as they occurred. Also in August of last year, the Massachusetts State Public Health Laboratory identified a cluster of 2 NDM E. coli human cases that were found to be highly related through WGS of the isolates. The cases were identified in April and August of 2023, and an investigation to identify common healthcare exposures was conducted, but failed to reveal any clear epi-links across healthcare facilities, which is what we're normally looking for. Then in September of last year, a third highly related NDM positive E. coli case was added to the WGS cluster. But again, further investigation into potential common healthcare exposures failed to reveal any epi-links across healthcare facilities. And in fact, the only commonality that we could find between these 3 human cases was that they all happened to live in the same county in Massachusetts. Then in December of 2023, the Minnesota Public Health Laboratory, which is part of the AR Lab Network, and Dr. Cole's team at Penn Vet, so part of the PGCOE that he described earlier, notified us of 7 NDM positive E. coli isolates, which included 6 veterinary and 1 environmental, that were highly related to our 3 human case cluster based on WGS. They were able to identify this link from the data that our lab had uploaded to NCBI. The veterinary and environmental isolates were all collected, of course, from the same veterinary referral hospital that we were working with and had been experiencing an ongoing CPO outbreak. Of note, the earliest isolate identified in the veterinary facility was from an environmental specimen collected in January of last year. Next slide, please. So upon learning about these links, we did something that we normally never do. We actually interviewed these 3 MDRO cases themselves or a family member. Normally with MDRO cases, all the investigative information we get is obtained from infection preventionists, laboratory data, and healthcare providers. So we slightly modified a draft tool that CDC provided to us that was under development for such case investigations and was aimed at identifying relevant animal exposures. And this slide describes what we found. So our human case A had a positive urine culture in April of last year. This was a 79-year-old female, generally healthy individual. However, she did own a dog that required extensive veterinary care from November of 2022 through July of last year at the veterinary referral hospital that was experiencing the CPO outbreak. Similarly, human case B, a 63-year-old male who was actually being screened while inpatient in a healthcare facility due to potential exposure to a different NDM-containing organism, but was found to be positive for this NDM E. coli. He did have extensive inpatient medical history, but also owned a cat that had an overnight stay in July of last year at the veterinary referral hospital with the CPO outbreak. And then lastly, human case C, 23-year-old female, also positive urine culture in September of last year, generally healthy, also owned a dog that had been hospitalized at this same veterinary referral hospital last September. Next slide, please. So as you can see on this timeline, it may be a bit difficult to see unless you're looking up close, and this was provided by Dr. Cole. Thank you very much. This NDM E. coli was first identified in an environmental sample collected in the veterinary referral hospital in January of last year, during the time that several clinical veterinary cases were noted to have occurred, and also overlapped with an extended inpatient stay for dog A, owned by human case A, as you can see on this chart. You will also note that case B and case C's animals both had stays at the veterinary referral hospital prior to their owners testing positive for the same NDM E. coli organism. Both animals were also present at a time when the CPO outbreak in the facility was ongoing and other clinical surveillance positives were being identified. So some of those 7 that Dr. Cole's lab notified us of. These 2 animals, B and C, even appear to have briefly overlapped with one another in the facility, but despite surveillance testing that was taking place, these animals just didn't happen to be captured in that surveillance screening. And while we can't conclusively state that in all 3 cases transmission occurred from companion animal to owner, the timeline and exposure history of the animals to the veterinary referral hospital prior to their owners being identified as colonized or infected certainly suggests this. Next slide, please. So as mentioned, we believe that these findings strongly suggest CPO transmission from companion animals to owners, which is not surprising in the context of this panel discussion. Of note, in 2 cases, a clinical infection did result in the owner, and also notably, none of these 3 pets was ever identified during the course of their veterinary care as colonized or infected with NDM positive E. coli. This example, I think, certainly highlights how silent transmission can occur in veterinary healthcare settings and households, as Dr. Cole referred to earlier. We don't know which companion animals and owners might be at greatest risk or at more risk than others. But here in our program at the Department of Public Health in Massachusetts, we're now sort of reconsidering how this might change our public health approach to investigating MDRO cases, particularly when no healthcare links are identified among cases that we know are highly related through whole genome sequencing. And then lastly, how should this information be communicated to veterinary providers and owners? Next slide, please. So what we learned is that veterinary healthcare settings face unique challenges related to IPC and MDRO transmission, including many items here that have already been mentioned. There's certainly a need for more awareness and education. Obviously, management and control of animal elimination in facilities is a particular challenge, especially when we're dealing with primarily gut pathogens. IPC infrastructure is often not in place, as has been discussed, and a lack of funding is also a challenge. And then importantly, access to laboratory capacity and expertise, including molecular testing and whole genome sequencing, is much needed. And then I think it goes without saying that many common infection prevention and control strategies can and should be applied across human and veterinary healthcare settings. And so I think there's an opportunity for our human health HAI-AR programs to potentially collaborate and support our veterinary partners here. Next and last slide. And then just lastly, to highlight some opportunities, I know that our colleagues, Dr. Shira Daron and Claire Feldman from Tufts, have presented to some members of PACCARB in December of 2022 on the importance of interprofessional collaboration to support stewardship and IPC efforts. And I would just extend this recommendation for collaboration to state and local public health departments, and particularly HAI-AR programs, just to more broadly and holistically address antimicrobial resistance and IPC challenges. We know that this cross-pollination really can lead to bidirectional support regarding outbreaks and best practices. And, I think even just sharing this information more broadly among state public health laboratories can open more opportunities. For example, our state public health laboratory was not routinely searching NCBI for non-human matches to our CPO clusters, and now they are. So that's a change. And I do think that developing and publishing standard tools, resources, and guidelines for state health departments to investigate these situations could be very beneficial. And next slide is my last slide, just contact information and some acknowledgements to colleagues. Thank you.
Thank you so much to all our speakers. That was amazing. So now we're going to transition to the Q&A session. And so raise your hand if you're on Zoom, or reorient your name card. And so Paul, if you'd like to start us.
Well, thank you to all of the presenters. Very much appreciate you bringing your expertise. I think, collectively, these stories demonstrate, again, the importance that we always talk about of One Health, and, how many different interactions that we have on either the veterinary or the human side, and how frequently are we asking questions in our histories about pet ownership or illness. One question I wanted to follow up on, and I'm going to direct this at Dr. Cole just in the interest of time. So, you mentioned, several folks mentioned that many of these animals where we've identified the CPOs or CROs are not clinically impacted by that. And so I just want, we've talked a number of times at PACCARB about the cost of, culture and susceptibility testing, and the challenge, that Dr. Alroy pointed out in that. And I made the point many times, it's hard to justify to a client $250 of diagnostics when we can treat for $30 or $40 of antibiotics. But I'm interested in you commenting on, of these various cases that we've talked about in your lab's experience, how many of these are actually symptomatic? So now that adds in this conversation, as Dr. Alroy pointed out, of having that conversation in complete absence of it impacting clinical treatment, and how many of these animals actually are being treated because of these organisms. So.
Yeah, we luckily just did this yesterday for another reason, but I've had 21 clinical cases identified through culture and susceptibility of those 150 animals. So it's not actually that small of a proportion that end up with CPO infections, or at least isolated from clinical specimens. We do a lot of culturing at PennVet, I will say, compared to other facilities, for a couple of different reasons. One, we're an academic institution, right, with advanced practitioners. And then on top of that, we do keep our pricing fairly low for culture and susceptibility, because of what we see is the impacts that has compared to potentially at other facilities. So I think you speak 100% right that cost is a huge barrier to doing the surveillance that we need to do for this. And also, it's also a frustrating result, right? When you get back a result that means that there's nothing left to treat. I will say, when I've gotten these from outside clinics too, right? Only about 20% of the caseload I see in my lab is from inside our hospital. But I will say the number one question every time is, what do I do for this individual patient? How do I treat this individual patient who has a culture that's resistant to everything? And while that's important, I also think there needs to be a really important conversation about, how do we stop this from spreading to the other pets in your hospital? How do we stop this from spreading to the people too? And so while the major concern, as was pointed out by Dr. Weiss it's very much based on that one-on-one interaction with the client, and the actual implications for broader public health implications are often missed and are not incentivized with sort of the structures that are in veterinary medicine.
Virginia? And if we could keep it to like one question, because we have a boatload of people here.
I got you. I have a quick comment and then a question related to the discussion about improving interoperability and informatic expertise and so on. I think in addition to the impacts potentially on public health, just antimicrobial stewardship in general. So the development of antibiograms and access and data mining across regions in the country and so on, I think is a really important point. I just want to say that again, because I think it's really important. And maybe you can't answer this, or maybe I'm asking the wrong question, but what do any of you think about the laboratories that don't have the kind of expertise that are doing routine, maybe culture and susceptibility? How do we address those labs that just are, maybe they don't even have a clinical microbiologist, they have some technicians, they run some samples, like how do you get them in the loop? How do you, in the context of particularly public health, but also general antimicrobial use?
You know, I think at the end of the day, a lot of these veterinary diagnostic labs are businesses. And so businesses have to look out for their bottom line and are subject to regulations. And they're also, are also staffed by people, I'm seeing a lot of promising, communications coming out of a lot of these big veterinary diagnostic labs with interest in participating in public health and stewardship. And I think there's a great opportunity to work with them. But right now, we're basically asking them to do things for free, right? And so unless we have funding for them or incentive either coming from somewhere, whether it's from the public health infrastructure or for grants, there could be a lot of different creative mechanisms to imagine how that could look. But we can't ask people to do things for free if public health really wants that information.
I'll just jump in and throw out, supporting the veterinary microbiology specialty as well and growing that. I think some great grassroots work has been done in the past few years. One of the benefits of the pandemic was actually that our board certification exam switched to online, which opened it up to a lot more people being able to take it globally, which has been really positive for growing our specialty college. But I think that higher profile, because of more people doing it, has actually led to some of these laboratories actually hiring board certified veterinary microbiologists now, which I actually see as a really positive change. And so what we can continue to do is to grow that specialty and show the worth of the veterinary microbiologist in those labs as well.
And I think it's tough to address because, like you said, the bottom line is a key component here, but this isn't a selling point for your average veterinarian because they don't know or to a large degree care about the methodological issues, the quality of the lab, CLSI guidelines and everything. So there are a lot of really good labs and there are a lot of labs that are kind of questionable. And we're seeing increased marketing of some labs that are doing completely unvalidated, typically genotypic methods to infer susceptibility. And we're seeing some of these actually get big inroads in some markets like exotics because they're now sponsoring, they fill the vacuum in sponsorship and they're pushing their products really heavily. So we run the risk of actually losing ground in some areas. So I don't know how we get it. Like really, we need veterinarians to understand more. And I think Stephen's point about getting more clinical microbiologists that are engaging with the veterinarians so they understand that there's a value in going to a lab that knows what they're doing and can tell them what they're doing is useful, but it's a tough area, I think.
Stephanie?
Hi, thanks to all the speakers. I'm like jumping out of my skin. I'm so excited to hear all of these public health talks and the investigation by Massachusetts and our speakers. Karen, it's great to see you here. And I wanted to echo what's been said about leveraging existing infrastructure of health department, healthcare associated infections programs. We do this work in humans among these high acuity settings where we see transfer of CPOs, and it's alarming to see it happening among veterinary hospitals. And I also wanted to echo this idea of the informatics exchange of information and add on that, we'd love to collaborate with getting more information out of, reliable laboratory sources. And if we can, that is, urban health departments or health departments in general get together to think about ways, whether that comes from CDC or other parties interested to leverage the infrastructure to get the surveillance data so we know what's happening out there. And then here's my question. And lastly is just, I think Dr. Cole, you were talking about kind of engaging local, like what are the ways you might recommend, suggest that health departments might engage local veterinary hospitals to use, IPC, better at the forefront when caring for patients?
Yes, certainly. We certainly very much valued our relationship with the Philadelphia Department of Public Health, and it was a savior for us. Really, it was when we were in sort of panic mode. So I can't echo the importance of that enough. When it comes to how we do it, I think is well, that's like the things that physicians like, right? We like continuing education credit. We like free food, right? We like those sort of things. So I think that, it's really about outreach to the individual ones. The biggest problem is that unlike in human medicine, the networks that exist even regionally within veterinary clinics are very loose, right? They're social media driven, or they come out of a need, right? So I've done some work in Philadelphia for our local hospitals on behalf of PDPH, but that's because out of the pandemic grew a network of regional hospitals to help with issues that we had with deferring care and things like that came out of the pandemic. But we've leveraged sort of these local networks now that have grown out of the pandemic to actually do some of this teaching at a local level, and offering to come out at no cost to give an infection prevention feedback could be at a cost. But the biggest problem is, again, the bottom line, right? These are small businesses mostly. And I think also there is a fair amount of consolidation occurring within veterinary medicine with like larger hospital groups as well. And so, engaging with these key players in larger groups of hospitals, I think would also be another way.
Thank you. Libby?
Thanks. I sort of wanted to piggyback onto all these shared resources. It always impresses upon me, and we are fortunate. I'm in North Carolina, where we have a large animal hospital nearby that we get to collaborate with. But I think what's really made the biggest difference in antibiotic resistance in humans over the past few years is that we were able to put federal funding to the state health departments to really help support antimicrobial resistance and stewardship. And I'm wondering how much I feel like we're seeing you as sort of the examples of excellence, but, is this something that PACCARB could support? We have a track record of supporting having stewardship in all hospitals, et cetera. And I just want your thoughts on, the role, and if you can see this expandable, and is that something that we should investigate as a PACCARB to support, of having embedded people focused on veterinary care? Because I feel like we talk a lot about, we send our patients down to use the scanners at the vet hospital and vice versa, but I've never seen the veterinary microbiologist from NC State at our micro lab. And so what can we do to help facilitate those collaborations to work for the state?
Yeah, I think that's absolutely something that can be done. I want to point to the Minnesota Department of Health having a veterinary CVT, or a certified veterinary technician infection preventionist, on staff that's available for veterinary specific problems and issues that arise. So Leslie Coleman at Minnesota Department of Health plays this role, and now she's honestly becoming a national role. What's really exciting is APIC. I don't know if I'm even allowed to announce this, so don't let it leave this room if not. But I know APIC has recently approved a group of veterinary infection preventionists getting together and formally forming a group which has been involved with our infection preventionists we have, and Leslie Coleman and some other leaders too. So I do think that there is absolutely a need to embed people within local health departments that have expertise and are approachable to veterinarians, because vets are used to reporting rabies suspects, and rabies is not our fault, right? and it's scary to think that something could be your fault, like with antimicrobial resistance. That's the feedback that I get, right? And I'm so glad the message this morning has been that these things happen. This is no one's fault, right? We have to deal with these problems. And I think that's a really important message to veterinarians, because it can be a little scary.
Thank you. Next on the list is Dr. Woodham.
Yeah, Thanks. So, like Paul, I was kind of thinking about the diagnostic issues and the barriers to diagnostics in veterinary practice, and definitely it starts with the client's reluctance to pay for diagnostics, but willingness to pay for antibiotics. And once they're out of the initial visit, then at all the stages, it's easier just to prescribe another antibiotic than it is to get the animal back in or try to get a sample collected. So I think that not just CREs, but a lot of the MDR pathogens that come to us in the tertiary care facilities have already been escalated through multiple rounds of antimicrobials before they get to us. And a lot of it is lack of access to or barriers to access to the diagnostics, and just kind of reminded me of our discussions about access in the global report. I think some of the similar issues at play, but also, as was brought up, access to expertise like clinical microbiologists and veterinary trained pharmacists. We have those in our tertiary care hospitals, but out in the primary care practices, they have difficulty accessing those resources. So for us to look for ways to help practitioners have access to the expertise and rapid, affordable diagnostics, I think those are critical issues to address this situation.
It looks like Julie.
Thanks so much. I'll try to be brief. Wonderful session. I learned a lot. I think my question really relates to the context of companion animal care delivery and regulatory levers. I think a theme that bubbled up throughout this is the sort of role of social networks and pre-existing relationships as a fundamental component of this working. I was really struck by your story, Ms. Cummings, about the sense that you called it serendipity in action, that vet referral hospital felt comfortable enough to engage with the Department of Public Health. And I guess I'm wondering, we heard a little bit about the legal framework that Dr. Alloy was trying to build up to get reporting to occur. But the reality is that, we rely on social networks, and Dr. Cole has a big network in this area, we're going to miss a lot of sites of care delivery, because I think companion animal vet med is so distributed. I mean, my own new city, when I went to go get a vet for my cats, I had a large choice from large corporations to one person who hung up a shingle. And so when we think about coordination for AMR, antimicrobial stewardship, what are the levers that are have a little bit more teeth, repercussions or incentives to engage these individuals beyond just goodwill? I mean, that's a foundational important part of this, but are there AVMA? Is it through financing in some way? I mean, are there a little bit more aggressive teeth to try to get individuals all on the same page? Thanks.
I'm happy to try to tackle that one, but I also welcome the other panelists to chime in on this too. I mean, I think as Dr. Weiss was pointing out, the regulatory space for companion animal medicine is not as robust as other spaces. And, when I think about what has teeth for veterinarians, I think, there are veterinary practice acts that regulate the practice of veterinary medicine, but we don't per se have a regulatory body over veterinary facilities, right? And certainly we don't have the incentive structures that exist within the human medicine, financial reimbursement. So that carrot is kind of off the table. And then, the stick approach I don't want to say it's not practical, but I have not yet seen, at least with AMR and stewardship, that model of it being used through the Veterinary Practice Act. But, that's certainly something we can consider. I think, as a public health entity in New York City, we really try to reserve the use of strong measures for those real extreme situations. And so we do rely so heavily on goodwill and voluntary collaborations as much as we can. But you're right, at the end of the day, especially when we are talking about building surveillance systems and, building infrastructure, it's not really sustainable to just build it on goodwill. And that's where I think the, policy levers might be in place to provide some kind of funding and infrastructure to try to, move it beyond that goodwill space.
If I can maybe jump in here, I think one of the problems you're dealing with right now is you're dealing with 95% of horses out of the barn. dealing with by the time you got carbapenem resistance, you've missed steps 1 through 100, right? You're dealing with step 101. And it's not to downplay the stories that we've had here. Like the CPE story is really important, something to address, but it's a very small component. And the biggest issue here is animal health. And why are we using antimicrobials? And that doesn't get talked about here. And that's something that we're really focusing on internationally, is we need to refocus the discussion on optimizing animal health, improving equity, improving education, improving access. All these things come into play because it's deficiencies in those that lead us to antibiotic use, which lead us to resistance, which lead us to more resistance. And when all discussion is on resistance at the end, we're missing it. And, we want to focus on these high profile things like CPE, but 99% of the problem isn't from them. It's from other things too. So we have to make sure that we're addressing the routine issues. And the routine issues are routine antibiotic use that are kind of normal situations, often things that we could be preventing through better health, through better education, through better engagement. So I'm certainly not saying don't pay attention to CPE. I'm not saying don't do surveillance. All these things are important. What I'm saying is don't forget the initial areas where we really need to intervene, because it doesn't matter what the organism is. If we optimize health, we're going to reduce the risks.
And just to bounce off that, I've been, one of the themes of today has been, right, preventing infection in the first place, right? That's been a huge theme across this whole thing. And so to drop off not only antimicrobial use, but just to highlight again, I think a theme across all this was infection prevention at the level of veterinary medicine as well.
All right, Joni, this will be our last question.
All right. It's directly related to this discussion. First of all, panel, this is wonderful. Thank you for great work on all your parts. So I did want to talk about the legal authorities, and that leads into this discussion, because just like in human medicine, veterinarians are, through their licenses, required to keep private information private. Animal medical information is also private. And so they're not allowed to share it unless, of course, some kind of infection or situation is reportable. So the legal authority for a veterinarian or a vet diagnostic lab to report to public health. Oh, and I should say that in general, veterinarians are required by law to report to their board of animal health. In our state, we have a few agreements with our board. So veterinarians report, say, blastomycosis to the Department of Health, and some other diseases, tularemia, to the Department of Health. But that's through an arrangement with our board of animal health. So veterinarians report to the board of animal health, and then the board can report to the Department of Health in order to have that legal authority. And what we did in our state was, a couple of decades ago, our veterinary diagnostic lab initiated this because they would have these situations where they really wanted to confer with public health, but they had this nasty little privacy issue in the way, and they would sometimes do it anyway. But the Board of Animal Health now has, as reportable on their list of reportable things, is zoonotic infections of public health importance. So when something like this comes up, and it's very vague purposefully, right? When something like this comes up, there's the legal authority to report it to the board, who reports it to the Department of Health. And my question had been, and maybe we've discussed it already, was for the panel, is how did you address the legal authorities in these situations?
Yes, certainly. I can say in the city of Philadelphia, the way that the reporting requirement was written, it was written as any culture yielding a CRO was reportable, and so it wasn't specific in either direction. We had obviously conversations with our Board of Animal Health in Pennsylvania. Pennsylvania also has some vague-ish language on purpose about reporting clusters or outbreaks of disease broadly in animals, and so that is also another sort of way that legally that was sort of navigated as well, because obviously when you have multiple animals being affected, then it's a bigger question.
Maybe I'll just add the CDC survey that I mentioned in my presentation. They found that of the veterinary diagnostic labs they surveyed, 95% of those labs were in jurisdictions where the reporting requirements didn't specify animal or human culture, but that actually led to some confusion on behalf of the diagnostic labs. They thought, well, I don't know if this applies to me or not. And so I think that was partially why we were motivated to make it clear within the New York City Health Code that we were interested in both human and animal cultures.
I'd also say I've experienced in the other direction too, right? If it's confusing, if you are a veterinary microbiology lab trying to report to a state public health lab that doesn't have it clear to them if they should accept this report too, right? So I've been on many calls actually with that being like, should I do this? Should I not? I don't know, and then they're like, oh, just put it through, this national surveillance network. And I'm like, I can't do that, right? So I think that there's a lot of confusion on both those sides for sure.
Well, we've run out of time. Unfortunately, we didn't get to everybody, but it was a really amazing discussion and incredible presentations. And I really thank all the folks on the panel. It was just quite near and dear to my heart for sure. So with that, we'll conclude the session, and thank you again.
All right. Thank you, Dr. Burbick, for moderating. And again, a sincere thank you to our panelists for joining us both in person and in virtual land. There are other questions, so I encourage council members to reach out to individuals separately. We are now going to break as we prepare for the public comment and innovation spotlight portion of our meeting. We're going to take 10 minutes. Please be back by 3:05 for a prompt start at 3:10. Thank you.
Produced by the U.S. Department of Health and Human Services.